Welcome to this session on osteoporosis in young people. Today we're going to talk about osteoporosis in younger adults, and I'm very pleased to be joined by Professor Jennie Walsh, who is based in Sheffield. Jennie, could you tell us a little bit about your role and your interest in bone health?
Yeah, Sean, thank you very much for having me. So I trained as an endocrinologist, so I'm a hormone specialist by background. And I started working in bone disease when I did my PhD. And I studied the later stages of bone development, so in people sort of from teenage to adult years, both in normal development and the effect of Depo-Provera contraception in young adults. And since then, I've gone on to become a consultant in metabolic bone disease. So I practice in osteoporosis, but I also have a particular interest in young people. So I see young people with low bone density and with a range of other rare bone diseases as well.
Excellent. So very much a specialist in this area. Thank you. So thank you for obviously sparing us the time to come and talk to us today. Just to point out to any listeners to start off with what we won't be covering, because obviously osteoporosis in younger people is a really complex topic and can come in many forms. And just to say that we're not going to be covering the very, very specific and unusual conditions of pregnancy-associated osteoporosis or transient osteoporosis today. So moving on to osteoporosis in younger adults, as I say, it's a very complex situation. So you might have some people who get told they've got a low bone density, but it doesn't mean they've got a raised risk of fractures or need any treatment and particularly have a problem. And in others, it's very much the reverse. They do need some sort of management or treatment. So understandably, this is going to be the cause of, I should imagine, a lot of worry and confusion, and sometimes helped along the way by a lack of knowledge, perhaps from some healthcare practitioners or GPs, where treatment might be offered where it isn't needed or not offered where it is needed. So if we start at the beginning, what do we mean when we're talking about young adults?
So really anything sort of from the end of puberty onwards. And usually when we're talking about bone density, we tend to think about sort of premenopausal women, because the menopause is sort of a natural change point for bone. And then the sort of equivalent in men would be up to about age 50. Yeah. In terms of the use of the word osteoporosis in younger adults, it does get used, and it's a very sort of convenient label to use because it sort of describes the framework that we're thinking about. But I think it's important to recognise that the pathological definition of osteoporosis is really a degenerative disease. So it's loss of bone mass, it's deterioration of the architecture within bone. And in younger adults, we're not really talking about a degenerative deterioration process. We're talking about people whose bones haven't developed the strength and the mineralization that we might expect. So it's kind of, people do use it, and I'm probably guilty of it myself, but I think it's important to understand that we're talking about a different situation in young adults than we are in older adults, where there's been a degeneration of the bone density and the bone structure.
Absolutely. Yeah, and I think that's a really important point to make. So sort of carrying on from there, when we do talk about low bone density not necessarily being a problem, when people have been labeled with that diagnosis of osteoporosis, it's not, as you say, it's not that condition that is potentially going to be causing them this sort of degeneration and multiple fractures. Is that right? Is this something that for some people it's perhaps a misdiagnosis that is something that means they're going to be able to carry on pretty much with normal life?
Yes, I think there are some young adults we see that do have low bone density that is having consequences, that they are having fractures. And particularly, we always get very worried if we see vertebral fractures, spine fractures. But that's the minority of young people who have low bone density. About half to 2/3 of your bone density is inherited. So it's part of your genetic makeup from your parents.
Yeah.
And so there will be people who have just inherited low bone density, and that's normal for them. It doesn't necessarily reflect that there is an underlying problem if they're not having unusual fractures. It might mean that down the line, when they're a bit older, that they might be more at risk of osteoporosis and fractures when they get to age-related bone loss. But right here, right now, it probably isn't a really big risk for them. Yeah. And that's because fracture risk in young people is generally not very high. The most important risk factor for fracture is age. And it's probably more important than bone density or any of the other things that we measure. And so a young person has a very low risk of the sorts of fractures we think about as fragility fractures, so spine and hip and wrist fractures. And so even if your bone density as a young adult is low, and even if your bone density means that you are at 5 times higher risk than an average young adult, that's still 5 times pretty much nothing. And so your risk is still really low. And I think that's quite a difficult concept to get across sometimes.
Yeah, absolutely. But a really reassuring message to get across. Yeah. So for people that do get told they do have osteoporosis, what's going on there?
So the sorts of reasons we see young people whose bone density we are worried about, it often is because they already have a known health condition which will increase their risk of having low bone density and fractures. So quite a number of people will have come to us because they have an underlying problem, which means that their bones are at risk, and so they've been measured and assessed because of that. We do also see young people who have presented with unexpected fractures. So somebody who's had a fracture with a low trauma mechanism that you wouldn't really expect to result in a fracture in a young person, and particularly people who have spinal fractures. And that is really uncommon, but it does happen. And so in that sort of situation, we'd be thinking about whether they could have some sort of underlying disorder that hasn't been diagnosed that could have led them to have low bone density. And so we would usually do a set of investigations to look for the sorts of things that could be underlying causes. And the kind of things that we sometimes pick up that people didn't know that they had are sometimes celiac disease, which causes malabsorption. And the symptoms of celiac disease can be quite sort of vague and non-specific, and people haven't really registered that could be the symptoms they're experiencing. So that's sometimes something that we pick up as part of our investigations. Occasionally things like an overactive thyroid, which hadn't yet become sort of obvious enough symptomatically that the person had presented with those symptoms. So we do a standard sort of set of investigations to check calcium, vitamin D, and any other markers that there could be something else going on. So that'd be our first port of call. And then we'd look at sort of the person as a whole and their lifestyle factors and whether there could be something around that that's impacting on their bone health. So whether that's kind of dietary, sometimes people with very restrictive diets or that aren't getting enough vitamin D, or high alcohol intake, and those kind of things, which sort of would probably in themselves wouldn't have caused low bone density and fractures, but could kind of layer on to other things to have sort of pushed them to be higher risk.
Yeah, absolutely. And in terms of trying to really understand whether somebody has got a problem and diagnosis, if you like, do we use the same method of scanning in younger people? Because obviously when people start to read about osteoporosis, they tend to read the typical, DEXA scan, T-scores story that we use for older people with osteoporosis. Is that the same here, or is it slightly different?
So we still use DEXA to measure bone density. In children, we do it slightly differently. We tend to do a whole body scan. As opposed to the sort of standard spine and hip scan that we use in adults. And that's because while bones are growing, it's quite difficult to monitor them while they're changing size and shape. So it's simpler just to measure the whole person. Once people are finished growing, so that's kind of late teens, then your bones have kind of reached that adult size. So it's that we do use spine and hip measurement, but instead of using the T-score, we would use a slightly different measurement, which is called the Z-score. It's also derived from the bone density, but a T-score is comparing an older adult really with an average young adult. And so a T-score is kind of asking the question, how much bone do we think you've lost since you were a young adult? And so that's not really a fair question to ask of somebody whose bones are still developing, because they haven't actually got there yet. And so we use a Z-score, which compares to an average person of your age and the same gender. So we're saying compared to, say, an average 25-year-old woman, does your bone density look within the range we'd expect, or does it look lower than we would expect? So derived from the same technique of DEXA, but we just interpret the measurement slightly differently.
Yeah, absolutely. And obviously you've touched briefly on some of the reasons why people might develop problems with their bones. There is quite a wide range. Obviously, there's a number of both common and very, very uncommon conditions and diseases out there and problems that might impact on bone health. Can you just tell us a little bit more about some of those and sort of the way we might manage that? Is it a case perhaps of addressing the underlying condition more than managing the bone health, or do sometimes they need to sit alongside each other?
Yeah, absolutely. That's the answer, really. So the sorts of situations where we see people at risk of low bone density. So in my clinic, for example, I see quite a lot of young adults that are having steroid treatment for things like muscular dystrophy, which also sort of has complications in the background which affect bone health, people with eating disorders, people with inflammatory arthritis or inflammatory bowel disease. And so often there is an underlying disorder. And absolutely, if it's the underlying disorder or treatment that's causing the low bone density, then that we do all that we can to treat the underlying disorder. So with an eating disorder, absolutely, it's about treating the underlying eating disorder and restoration of weight and normal periods. In somebody with an inflammatory disease, if their inflammatory disease is well controlled, then that will reduce the risk to their bones. If it's somebody that needs steroid treatment, as most clinics would do anyway, keeping their steroid dose to the minimum will help to protect their bone health. But then sometimes there does come a point where everything that can be done has been done to treat the underlying disorder, minimize the steroid exposure, but the person still has low bone density, and if they're having fractures, then we might think that we need to step in and actually do something more specific for their bones, because we've done all we can in managing the background factors.
Yeah. And would that sometimes involve some of the drug treatments that people might be familiar with, again, in more ordinary osteoporosis? Because there's, of course, that very complex situation where these drugs aren't licensed specifically to be used in certain conditions, such as younger people, but there may be cases where they are used.
Yes, there are. And as you say, we always think about using drug treatments really carefully in young adults, because we would only use them if they're at high fracture risk right here, right now. So that would mean somebody who we're seeing having low trauma fractures, or somebody where we're seeing a decrease in bone density. So we know that there's ongoing bone loss that we need to step in and stop. Usually our first line treatment would be, as it is with adults, a bisphosphonate. And they're not licensed for use in young people, but there is a reasonable amount of clinical experience that we can draw on, and from other bone diseases as well. So things like osteogenesis and perfecta, there's really good trial evidence there to show kind of the use of bisphosphonates in young adults. So we sort of mix together the evidence base we have from other bone diseases in young adults and from what we know about osteoporosis in older adults. But we would always have a conversation with that young person to discuss the risks and benefits, make sure that they understand that often we will be using the treatment off license, and we would try to use the treatment for the shortest possible time. And that's a little bit of a difference with older adults. Usually with older adults, we'd say, okay, you need treatment. So you'll be taking your alendronate tablets for 5 years or having your zoledronate for 3 years, and then we'll review. In younger adults, we're really trying to minimize the use of the bisphosphonate. So we'd keep reassessing. And if the risk factor had been resolved, then we'd try to stop the bisphosphonate before the end of that sort of standard course of treatment. So we'd use them slightly differently.
So very much an individual decision rather than, general approaches to treatment. Yeah. And again, very reassuring. It's nice for people to know that if they've been told they've got a low bone density, it's not that they must be seen by somebody and be put on treatment, in the way that older adults might, and that, but if they are put on treatment, that yes, although it's unusual, it's going to be closely monitored, and it's considered to be a good decision for them at that point in time. So again, something we've very briefly touched on, if somebody has a fracture, somebody who is not necessarily already aware that they've got an underlying condition that might perhaps affect their bone health, but they suddenly out of the blue have a fracture or fractures, which starts to raise that question. What investigations might be done then? What might happen to look to see if they do have a problem?
So yes, we usually start with bone density because sometimes people do just have really odd fractures. If the mechanical conditions are just right, sometimes people with normal healthy bones can manage to have slightly unusual fractures. And so if that does happen, but your bone density is normal, then that's very reassuring that it probably just was, a slightly freak set of circumstances that led to the fractures, and you probably wouldn't need any further investigations. But if we did identify low bone density, then we'd go on to do a workup to look at calcium, vitamin D, thyroid, celiac test, testosterone, estrogen, and kind of all the sort of underlying things that could be affecting bone density. And we'd look at kind of any family history, other factors, lifestyle factors, and see if we could sort of put that together to explain the low bone density.
Absolutely. And again, that's something that is going to be very specifically managed, I would think, by a specialist as opposed to at primary care level. Would that be a safe assumption?
Yes, so it would be very reasonable for primary care to request the bone density scan, and usually from that you'd get a recommendation either saying things look normal, there doesn't seem to be a problem, or maybe bone density is a little bit below average, but they don't look like there's likely to be an underlying problem, but it might be sensible to do another bone density scan in a couple of years to make sure that there isn't an ongoing bone loss. But if the bone density is a lot lower than we'd expect for age, and we think there might be something else going on, then usually the recommendation from the bone density scan would be that the person needs to be seen in a more specialist clinic to have those additional investigations and sort of talk through whether any further action is required.
And would that be to see, the specialist who would deal with any osteoporosis in the given region they're in? Or would there ever be a situation where there would be a suggestion that they seek out more specialists, for want of better, somebody with a very special interest, such as yourself and other similar people in your situation?
Usually the patients that end up coming to us from other hospitals are people that have had all of the investigations done.
Right.
And it seems to be a bit of a mystery why they've got very low bone density. So usually the local hospital clinic can do the investigations and will be able to sort of figure out if there is an underlying problem and what the appropriate action for that would be. So the people I get sent tend to be the people who've had all of that done, and nobody can really work out why they've got unexpectedly low bone density and fractures. And so they'd come to us for potentially more specialist invasive investigations, and to have a decision made about whether they might need treatment.
Yeah, much more complex cases, absolutely. But it's it's something that we often hear about when people phone us on the helpline. It's that sort of situation where somebody finds themselves in what appears to be quite a complex situation, and they're struggling to find, access to the right types of help. So, it's good to know that they can go back to their GP or whoever and say, perhaps a referral to the specialist team might be a useful thing, and they can follow that through. Do GPs, do they have a system where they can get guidance from specialists? I know we sometimes hear about that in individual areas. Is that a bit of a universal thing where GPs might be able to contact specialists without necessarily referring the patient, just to ask for a bit of guidance?
Yes, most local areas will have a mechanism for GPs to contact their local hospital. There's also a national system of e-advice and guidance. I don't know if you've come across that, but that's GPs can log on to the NHS e-advice service and actually send a query to anybody that's available on the e-advice service in specialist clinics.
Oh, that's really useful to know. So if somebody is in this situation where they've been told they've got a low bone density, do they need to go back and be reassessed again? If there's somebody that's not identified as being particularly high risk right at this point in time, do they need to be reassessed again within the next few years, or is that perhaps something that would be put off until later in life?
Again, it depends a little bit on the individual situation. So if it's somebody who does have potentially sort of a couple of active risk factors that could be affecting their bone density at the moment, then we might suggest another scan in a couple of years' time. If it's somebody who doesn't really seem to have an active problem at the moment or any reasons why we'd be worried about their bone density, we might say more, they're a bit below average. It might make sense for them to have another measurement if they're a woman when they become menopausal, or if they're a man at about age 50, at the age when we'd start to think about their fracture risk a bit more actively. And so it might be sensible for them to have a measurement sort of sooner in that phase of life, so that we can sort of be proactive about thinking about osteoporosis treatment in later life if they need it.
Yeah, absolutely. That makes sense. And we've touched a little bit on treatments briefly when we were talking earlier. And obviously you've mentioned the bisphosphonates, which are very well-known treatments for osteoporosis. Are there specific treatments that wouldn't be used perhaps in the younger population, or are there treatments that if they are used in younger adults, they tend to be, specific ones? Or again, is it just very much the individual and what their case might require?
Yeah, it is quite individual. Certainly, we wouldn't use drugs like teriparatide in people whose bones are still growing. So that's a hard contraindication. So we wouldn't really use those drugs in people at sort of under the age of 20. But there are situations where we do sometimes use other drugs in young adults than bisphosphonates. I've got a few patients that have had treatment with teriparatide, but they would be really unusual situations and quite unique situations.
Yeah. And how about hormonal treatments? And obviously, again, you sometimes hear about HRT and testosterone for men, but also I know in the past, there's been sometimes occasional use with things like the hormone contraceptive pill and those sorts of treatments too. Are they something that would, still be considered in the right situation?
Yes, absolutely. So there are some groups of people who will have low bone density, and the primary reason is because they have low estrogen if they're a woman, low testosterone if they're a man. And so one of the common situations we would see that is perhaps people who've had treatment for cancer in childhood. And that's been an area of my practice, working with patients who've had childhood cancer treatment. And so a lot of those patients then would use estrogen replacement, with the proviso that there are some situations in cancer where we wouldn't want to use estrogen. So obviously somebody who's had an estrogen sensitive cancer like a breast cancer, or sometimes people who've had radiotherapy, which could include the breast area and things like that. But if the underlying problem is that you don't have estrogen or you don't have testosterone, then it's common sense that you treat the underlying cause by replacing that. There's not much evidence in younger adults as to what the best form of estrogen replacement is. There's not really good evidence to say whether young women should take the contraceptive pill as estrogen replacement or whether they should use HRT. So in that situation, really, probably the important message is what matters is the estrogen, and then just finding a preparation that works for that individual person. As long as the estrogen's going in, it doesn't matter too much what format it's going in, whatever works for that individual.
Absolutely. Yeah. Not to get hung up on being the right or the wrong one. It's the underlying issue, definitely. So moving on a little bit with the sort of, I suppose, living with osteoporosis for those people that do have a problem. And I suppose even for those that have just been told that they've got, some degree of low bone density, which might need to be kept an eye on. Again, they might be, looking this up, reading online, finding out about it, and seeing messages perhaps that are aimed at the older population, perhaps that are more fragile, that have had multiple fractures and are being given sort of different messages. And obviously lifestyle, exercise, diet, nutrition, all of those issues that we know are so important for bone health. Some people might worry about doing those because they might read in, as I say, in situations for other people that perhaps they might be things to be a bit cautious about. But would that be the same here? Would we actually encourage those, sort of good exercise regimes and, to really make that part of their bone health management?
Yeah, absolutely. Exercise is really, really important for all aspects of your health as well as your bones. The things for people who have very low bone density and that we are worried that they are at risk of fracture, the things we would say generally are not things where you put a high impact force through your spine. So generally for our young adults with sort of osteogenesis imperfecta, brittle bone disease, the advice is the same. So no horse riding, no trampolines, no bungee jumping. But aside from things like that, where there's likely to be a sudden force through the spine, any sorts of usual types of, gym exercise, non-contact ball sports, running, is all good. And if there's anything that you're kind of particularly worried about, you can always ask your healthcare professional for a bit of specific advice about exercise that's suitable for you. But yeah, it is really, really important for your bone health, and particularly for, young adults who are still in those later stages of developing their bones. That's when it can be a really powerful intervention, because your bones still have the capacity to really respond to that in the way that an older adult's bones don't. And so I often, say to my younger patients, for somebody who's, 20, I know the prospect that one day you will be 40 or 50 is absolutely inconceivable. But this is about, doing your future self a favor, and everything that you do now to make your bone strong is bone strength that you have in the bank now for when you get to be 50 and your bone health starts to become more of a concern. So yeah, it's drink your milk and jump up and down. It's not rocket science.
Yeah, incredibly important message. And young women with low bone density or a diagnosis of osteoporosis, they might be thinking, gosh, if I want to become pregnant, or if I do become pregnant and I want to breastfeed, is this going to be a problem? Is this something I should be, taking extra precautions around or doing anything differently? There might be that background concern. And they might also perhaps be reading about that very different and very rare condition of osteoporosis associated with pregnancy, which is not the same as this. What message do you give there?
Yeah, it's a really good question, and one that we are often asked. We would say It's really just about advice to do all you can to maximise your bone health during pregnancy. Pregnancy does cost a little bit of your bone density because the baby is kind of drawing calcium from you to build its own skeleton. And so it's really important that the mother has a good dietary supply of calcium and vitamin D, so that as they're kind of using up their own calcium to make the baby, that they keep the supply coming in and keep that replenished. And the same through breastfeeding. And bone density does decrease a bit from pregnancy and breastfeeding, but we do all we can to reduce that, and it recovers. There is research to show that bone density decreases a bit during pregnancy and breastfeeding, but about 12 months after the end of breastfeeding, then it does recover and it does replenish. So it's a temporary change. And yeah, talk to your healthcare team, and they will give you good advice about what you can do to protect your bone health. And then that sort of also raises the issue about people who might need bone treatment like bisphosphonates who are considering pregnancy. And obviously that does make the situation a little bit more complicated because bisphosphonates are contraindicated in pregnancy because they can reduce the baby's calcium levels and very, very rarely have an effect on the baby's bones. So in somebody who is a young woman who we're talking about potentially treating with a bisphosphonate and they might be planning a pregnancy in the future, we'd always make that part of the conversation about thinking of the timing about when they want to plan their family and then how that would affect the advice we'd give around using bisphosphonates.
Yeah, absolutely. And also another point there I perhaps would think is, if somebody is pregnant, going through pregnancy, going through breastfeeding, it's probably a time not to be having another bone density scan.
Yes, absolutely. A bone density scan, firstly, for some of the practical reason, it's a really low dose of radiation. It's such a tiny dose of radiation that we do DEXA scans in healthy children for research studies. But obviously, we wouldn't want to do anything that's a radiation scan in somebody pregnant unless there was a really, really urgent indication. And also because, it's often not very helpful at that point because it will show a little bit of a decrease. We expect to see that. And so usually what I'd do with women who are having a pregnancy and breastfeeding would be say, okay, we'll remeasure your bone density at the point where we'd be expecting recovery. And then we can see sort of where the recovery's got to. And then if we need to think about anything beyond that.
Yeah, absolutely. Really good information. And for a lot of people who do have a low bone density, they might be worried about, what does this mean when I do get older? Does this mean that I am automatically going to become an older person with osteoporosis and I'm going to have lots of fractures, and this is going to carry on through, throughout my older age? Is that necessarily always the case?
No, not always. Everybody's bone density does decrease a little bit as they get older. And so if you are starting with lower bone density, then your bone density will reach a lower level sooner than someone started with more bone in the bank. But your risk of fracture is dependent on a number of other factors than just your bone density. And so we would always consider the whole person. So it's about your bone density measurement, but it's also about any other background health problems, your lifestyle factors, your family history. And so we wouldn't automatically say, once your bone density reaches this threshold, absolutely high risk, we're really worried about you, you need treatment. We would always consider you sort of as a whole person, and your bone density is an important part of that story, but not the whole of that story.
Yeah, absolutely. But just something to be aware of, and perhaps when, so a woman is postmenopausal, or if a man is, 50s, 60s, it might be a time to perhaps raise it with their GP at that stage and say, this was an issue when I was younger. Is it something we need to look at again?
Yeah, and I think that's really sensible timing, sort of about age sort of in your 50s, because that's the age when bone starts to change, and it's a really sensible age for us to intervene and do something preventative if it looks like you might be at risk.
Yeah, brilliant. So, obviously, I'm sure these are questions and issues that get raised in your clinic. There's certainly things that we hear about on the helpline. osteoporosis, being told that you've got a condition and maybe having fractures as well, but particularly as a younger adult, it's going to have a lot of impact on other areas in life, that might affect a range of things. I mean, from work to finances to relationships to emotional states, to that whole package of life and who you are as a person. And some people might struggle, as we said, with the idea of being associated with having a condition that's, often thought about as being an older person's condition, and the connotations that has. Obviously, our charity, we've got a number of useful resources on our website, lots of information about all of those different things, from how to look after your bones, lifestyle, drug treatments, living with osteoporosis, even, coping with fractures, and many more Bone Matters films on these issues as well. So do have a look at the website, and do have a look at the signposting at the end of this on the page here. I think we've covered an awful lot in quite a short space of time here, but are there any other points that you would like to add that you feel that we might perhaps not have covered at this stage, Jennie?
I think what you mentioned there is really important, that being given a label of something that feels like an older person's disease is a real sort of shift in your identity and does raise a lot of worry with people. And I think, again, when we were sort of talking about things to do with like exercise and things like that, I think be sensible, but you don't need to be fearful. And if there are particularly things around issues around kind of work and employment and things like that, then I'm sure, all other healthcare professionals would say the same. I'm always happy to write letters explaining things for employers to say, these are the sorts of reasonable adjustments that person would need in terms of making sure they've got, proper setup at their desk, and that they're allowed to get up and stretch and fidget if they need to, or that they shouldn't be doing unsupported heavy lifting. And so, your healthcare professional can always advise on that, and are generally pretty happy to sort of write letters for you explaining things to employers or potential employers or educational institutions to support you around that.
That's really useful to know. That's a question we often get on the helpline, when people are in this situation. So that kind of support is going to be incredibly useful. Thank you. Amazing discussion, so much information on a really difficult topic. This is something that doesn't get talked about a lot, and perhaps there isn't enough information on it yet. So it's been such a useful discussion, Jennie. Thank you so much for coming to talk to us today. That's been really, really helpful. Thank you.
Oh, thank you very much for having me, and thank you for really well planned questions. I think you've chosen all the really important things that we needed to talk about that are useful for people to hear. And I would second your signposting to the ROS resources. They are all great.
Oh, that's good to know. Thank you. That's lovely. Well, thank you for joining us today. And if you've been watching, I hope that you found this useful too. So remember, do look at the signposting and have a look at the website. Thank you very much, Jennie.
Thank you.